can I have one of those?
Yeah.
Is it on?
Yeah, not right this second.
Hi there.
All right, thank you very much. That might have been terribly lost.
Yes, it'll, in just a second.
How you doing? Took 2 hours, almost 2 hours.
So there was a gentleman who called me on my way here, and I didn't know what to tell him about how to get here. Would you mind talking to him if I get him on the phone?
I'm not familiar around here. Let's see.
Oh, we got a whole group of people.
Talk
Between
to
the bunch
this
of us, we could help
Does
him.
he
If
have
answers.
GPS?
He was calling me from a landline.
But in his car, does he have GPS?
I don't know.
Okay, you're good to go.
Thank you.
Yeah.
Testing.
See, you have, yeah, okay.
Hello there, it's Bernadette Greenwood and the Prostate Forum of Orange County. We're all here in the church at 838 Euclid and willing to give you directions and talk you in.
17.
So if you get this, give me a call. Otherwise, hope to see you later this evening. Thank you, bye. Yeah, he called me thinking I knew how to get here, and I'm like, I'm not from here. I don't know how to get there. So it was funny.
Oh, did you really? Well, it turns out that there was a other competition that couldn't have been published in the map. It's a two-stage. It's in the hand. So I believe that chiropractors, and they went to masseuses for 3 or 4 months, and chiropractors and acupuncturists, each one of them helped me a little bit. And then my wife says, why don't you get one of those patches on the back of your neck that contains different things that are
All back here that you don't want to burn a hole in that thing, right? So we put little cursors here, so if the temperature exceeds a preset threshold, the system shuts off with no user interaction. So it's very precise and very controllable. So initially we deliver a dose at around 99 degrees Fahrenheit just to see where the tip of the thing is, and then we crank the energy up, and that's when we can see the irreversible damage estimate. So I presented this technique in Europe at the European Congress of Radiology back in 2011, and we've published a number of textbooks and chapters and papers and abstracts and posters, but our phase 1 results are being submitted for publication as we speak. I'm working on the manuscript. But here's a case study that'll help you understand how it looks after the treatment's done. So we see a tumor here. This was a 3 + 4 = 7. You could see it here. It's bright on the high B value, it's dark on the ADC. And then when he came in for treatment, we had a coagulation necrosis estimate and a thermal map, and then the final product. Once we were done and we gave gadolinium contrast, you could see this big cavity here. That's a slice as though I was slicing them like a loaf of bread from top to bottom. And here's a view from the side that shows that cavity where the tumor used to be and is no longer. So how do we assess success? We biopsy. The only way to know if we got it is to stick a needle in it. So the patient comes back at 6 months, and whether or not there's any imaging evidence of tumor, we put needles into the treated area to make sure nothing microscopic is brewing that's going to declare itself down the road. And the other good thing about laser is we've got a nice tight margin between the treated area and the untreated area. Unlike RF, HIFU, and cryo, where you've got like a 10 millimeter transition between treated and untreated tissue, we don't want want some fluffy border. We want to know that's dead, that's alive, and that's the margin. And we get that with this, and it's usually around 1 millimeter thick. So, based on everything that we've done, in phase 1, we didn't kill anybody, which is good. Phase 1 is to determine, is it safe? And it's safe. We could do it in an outpatient setting with conscious sedation. Patient walks in and walks out and does fine. We have a marginal recurrence rate. Last time we crunched the numbers, it was 22%. Whole gland therapy, whether it's radiation or prostatectomy, the recurrence rates are anywhere up to 30–35%. And we don't have the morbidity associated with whole gland therapy. The men who have had recurrences and went on to whole gland therapy, only about 5%. Some have opted to be lasered again. Some have opted to go on to active surveillance. If we treated a Gleason 7 on them and down the road they had a positive biopsy that was Gleason 6, some guys will opt for active surveillance if it's low-grade, low-volume disease. Most importantly, patients are retreatment viable after our treatment, whether they want more focal therapy or whole gland therapy. We don't hurt anything, meaning the surgeon can go in and do prostatectomy, and we didn't put a bunch of scar in there, we didn't put a bunch of necrosis in there that's going to ruin the surgical dissection. And also important, there's a continuity of imaging modality. MRI for detection, MRI for localization and biopsy, MRI for focal therapy delivery, and certainly MRI for follow-up. And when we look at the results of this study, keep in mind we've got a large cohort that's broken into 3 groups, and I'll just talk about 2 of them here. We have treatment-naive men that never had anything ever, and we have a salvage population where these guys have had the kitchen sink. They've had ADT, they've had brachy, they've had proton, they've had everything, and the cancer comes back. That's a salvage patient that will go in and will laser just to be palliative and life-extending. So the third bucket of patients that we have is HIV-positive patients, and I just put them in with the treatment-naive guys because the one unique thing about them is that they're HIV-positive, but other than that, they're treatment-naive. So in all patients, we saw around a 45% decline in PSA after treatment at 1 year. That's pretty good. In the salvage population, when we break them out away from the rest of the group, their PSA decline is like 81%, but that's because at presentation, they usually have a much higher PSA to begin with because they've had multiple treatments, they've had radiation, they've got recurrence, and their PSA goes through the roof. And in the treatment-naive men, the average PSA decline for them is 41%. I'm going to go backward and I'm going to talk about 2 other things. There's an International Prostate Symptom Score and a Sexual Health Inventory. These are surveys that are benchmarks of urologic function and sexual health. And we like to see these numbers bounce back to baseline after treatment. We don't want them to go way down or way up. We want everything to stay at a level that's not of statistically significant change. And we were able to achieve bounce back in both categories in all patients. So that's the update on the focal therapy trial. Now let's talk about biomarkers, genomics in particular. By definition, a biomarker is any characteristic that's objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic response to a therapeutic intervention. The way I'm using genomics in our practice is to evaluate pathogenic processes. We take men that have known cancer and we run genomic profiles on them to see what unique markers they possess that could give us a window into their future. Of all the tests that I've used, and I've used them all, we use Prostavision for a long time because Prostavision in the literature has lots of runtime. Prostavision is an evaluation of 2 genes and 2 genes only. One is called ERG and the other is called P10. I'll talk about those a little bit more. These other tests are 20-something markers and Decipher is 20-something markers. But the thing about Decipher is it was used post-prostatectomy to determine if men needed radiation on top of their prostatectomy to keep them alive, right? If a guy had a really high-risk profile, with Decipher, they would radiate him on top of doing a surgery. So you can tell I'm a super shy individual. About 3 years ago, I went to the owner of this company and I said, when are you going to do Decipher on cores, on biopsy cores? He goes, never. And I said, why not? And predictably he said, because cores are inaccurate, they're garbage, why would I do that? And I said, what if I gave you gold? What if I gave you cores that were MR targeted, that were right through the center, the worst part of the tumor, and I gave you 20% core involvement or more? Could you extract enough RNA out of that sample to run Decipher on that tissue? He's like, I don't know, let me think about it. So fast forward to February 2016, Decipher for biopsy was released. So what I did was I went back in my population and I ran that test on as many men who would consent to do it. Let's go back and let's talk about cross division for a second, because that's all I had until February 2016. So ERG is all over the literature as an indicator of time to biochemical recurrence, acceleration or progression of disease. P10 is all over the literature describing immunosuppressive ability of the man. So every guy is born with 2 P10 genes, right? So if one or both of them are missing, that could be an indicator of poor immunosuppressive ability, okay? And I liken it to riding a bike. ERG is like the bicycle, and if you're not overexpressing ERG, you're on a backcountry road, nice and flat in the shade, taking it easy. If you're overexpressing ERG, you're on a wild mountain bike ride down a hill, okay? P10 is like the brakes on the bike. If you're missing the front, you still got the back. If you're missing the back, you still got the front. But if you're missing both, you might be in trouble. So that being said, we'll just look at the scores and how they shake out. A patient that's not overexpressing ERG and has both his P10s is a low score of 2. A patient who is not overexpressing ERG but is missing 1 P10 is a 4. A patient with both P10s intact but overexpressing ERG is also a 4. And the high scores, the 6 and the 9, those are guys who are overexpressing ERG and missing 1 or both P10s. And then I never like to see insufficient tissue, but that does happen sometimes when a patient comes back with only 3% tumor in the specimen. We can't get enough RNA out of it. So remember I said that Decipher was done post-op. Now it's done for biopsy, and we're able to evaluate 22 genes clinically, and in a research setting, there are different pathways that we evaluate, up to 1.4 million genomic markers to identify outlier genes and symphonies of aberrations present in men that don't respond well to any therapy. So the report for the clinical assay looks like this, and the report for the research result looks like that. Cooperberg and Ross did a lot of publication on Decipher with whole mount, and obviously they proved that this was a good way to risk stratify men and to learn more about what patients were more prone to prostate cancer specific mortality. So let's look at some real world cases. Remember, I didn't have this test available to me until February of last year. So I went back and I got the pre-treatment specimens on as many men that would consent to it. And I know what happened to these guys. They're our patients and I know what happened to them. So I took these specimens and I got their Decipher scores and their ERG and P10 scores. This guy was treated for 4+3 cancer, and he had his laser in September 2015. His nadir was 0.58, which is the lowest level it went to post-treatment. He had a low-risk cross division, low-risk Decipher. Predictably, he had a negative 6-month biopsy, so it appears we were able to achieve oncologic control in him. Then this guy, 66, Gleason 6, he had a PSA of 2.1. We did the laser on him in December. His genomic profile was low to intermediate, and he had a negative 6-month biopsy also. Now look at this guy. His Decipher score was way up there. He's like 0.75. He had his laser back in 2014, before I had this test. So he had a negative 6-month biopsy, but then 2 years out, his PSA crept up, and he had recurrent 3+4 at 2 years after treatment. So what did this tell me? If I had known this back in 2014, I might have warned him, and I might have said, you know, focal therapy may or may not work. If it doesn't work, we could try it again. If it still doesn't work, it may be time to move on to whole gland therapy. This guy, when we look at his Decipher score, he's the highest Decipher score in my database, 0.82. 60 years old at the time of this presentation. He was treated at the age of 55 for Gleason 6. He natored out at 4.1, not a significant drop. PSA went up to 6 in August of 2012. The laser was repeated in 2012. He natored at 3.4, still not very low, and then it crept back up to around 6 in January 2016. Lasered him again in August of 2016. This guy went on to develop colorectal cancer, and you notice he was promoted from 3+3 to 3+4. And so if I had known that he had a 0.82 Decipher score, it would have been a very different conversation at the time of his consent. I had some other information about him from Decipher. The research panel that we ran on him showed a gene called GX2, I believe, that was an indicator of colorectal cancer. So it would have been nice to know this 7 years ago. But we're glad that we have the test now, and we run it as often as we can. And when I look at a small cohort of 37 men who had either Decipher or Prostate division done, the biggest cluster that I see is a group of 10 men that had negative 6-month biopsy, and they had negative ERG and negative P10. So I think it's safe to say that guys with low-risk genomics are safe in a focal therapy paradigm, right? And then these 4 guys had lower intermediate risk Decipher, and they also had negative 6-month biopsy. The only cluster among the positive 6-month biopsy guys is this group that had overexpression of ERG and were missing 1 P10 gene, which is kind of weird because the way the test is marketed, they say that if you're missing both, you do worse than if you're missing just 1. But in my experience, I see men do worse if they're missing just 1, not both. But I think I just need a bigger number. I only have 3 guys. So I want to show you something else that I did. This is a confidential slide that was presented to me earlier this month, and it's the result of a paired cohort study that I put together. I took 7 men in the phase 1 study who did lousy on focal therapy, that progressed, that were promoted, that got bone mets, and that didn't do well with focal therapy. I took 7 of them. And then I went in the bucket of guys that did really well and responded, and we were able to achieve oncologic control in them. And I paired them up. I gave these guys each a buddy that looked just like them in terms of age, Gleason score, and geography of where the tumor was located. And I ran the 1.4 million genome panel on both groups. And look at what I found. The responders who did well on focal therapy are the green bar. The non-responders are this brown bar. And what you'll notice is the upregulation of genes in the responders and the downregulation of genes in the responders is exactly the opposite of the non-responders. And I found on the order of 30-something outlier genes that may hold some value in risk stratification and prognostication. So the way that it was done was we had 7 men who responded, we had 7 men who didn't respond. Of those non-responders, we had 3 that progressed, and we matched them to age within 5 years, Gleason score, zonal location of tumor, did a paired analysis on responders versus non-responders, untargeted and targeted gene expression analyses were performed, and I got grid signature scores on everybody. It's been published in the literature by other people who've investigated the grid test with the 1.4 million genome panel. The bottom line is, when we do any kind of biopsy, the target must be hit. These tumors possess so many different features. We've got to find the worst of the worst, stick a needle in it, get the tissue, and evaluate that. We can't be poking needles all over town hoping we get something that matters. It's just not logical, in my mind. There may be people that believe that, but I don't. And I used an example of symphonies. You got Mozart Piano Sonata in C major and Rachmaninoff Isle of the Dead. This is what I would categorize as a complex symphony, and this is a simple symphony. I don't think we've been looking at the right genes for 30 years. I think we can discover things that we didn't know, and we may have new nomograms in the very near future that are going to help you guys get off on the right foot right out of the gates. The minute you're diagnosed, somebody will be able to look at you and tell you where you need to go. Do you need to go on active surveillance? Do you need to go to whole gland therapy? Will you respond to ADT? Will you do better with radiation? These are important questions that need answers. So Hippocrates said it's more important to know what sort of person has a disease than to know what sort of disease a person has. And that's where genomics comes into it. So in summary, there is an emerging role for integrated biomarkers that are both diagnostic and prognostic, including PSA that's taken a beating over the years, multi-parametric MRI, MR-targeted biopsy, Gleason score, and genomics. And I'm confident that new nomograms are going to be on the horizon, and predictive cancer probability maps will be based upon machine learning. When we look at the role of the pathologist, there's known evidence that says pathologists suffer from inter and intra-observer variability, meaning if I put a core in front of a pathologist in the morning and put that same specimen in front of them in the afternoon, they may call it two different things. That's intra-observer variability. I could put it in front of one pathologist and then a different pathologist, and between the two of them, they'll call it something different. That's inter-observer variability. So machine learning, I think, will help us to do edge detection, cellular architecture analysis, and be able to look at the specimens and describe them, and then still have the pathologist bless it, you know, but I think machine learning is going to help us a lot. And we need more randomized controlled trials to validate the things that I'm observing in my lab and in this small series. So I'm hoping that international multi-center trials will contribute to this body of knowledge. And here's a bunch of references that I can provide to the team. About 4 years ago, I formed something called the International Laser Network. I had learned that a couple people read about our technique and tried to reproduce it in their practice. And the FDA MAUDE database is a great place to find out what issues are associated with certain devices and their use. So I saw that some patients were getting rectal fistula and other problems. So instead of going up to people and being confrontational about what happened and how did it happen, I formed this consortium with people from the NIH and the Mayo Clinic and Emory University, University of Toronto, Radboud University, Nijmegen, UCLA, University of Chicago. All over the world, folks came into this consortium to talk about what do you do, how do you do it, who do you do it on, and what are your results. And if you could come to the meeting and disclose what's going on, great. And what I'd like to do is bring everyone together to keep men safe and make sure that everyone's doing it the right way and the safest way. And that we collect the data at the same time points, and that we harmonize not only the technique that we use, but the intervals of data collection so that we can have an international multi-center study. So the guy over here on the right is Jürgen Futterer, who's the president of the International Laser Network. He's at University of Radboud in Nijmegen, and this is Sangeet Ghai from University of Toronto. He's the vice president, and I'm the founder, secretary, and treasurer. And so you know who else contributed greatly to this work? Dr. Roger McNichols was the PhD scientist that I worked with, who when I flew to Houston and put everything on a conference table, he was the guy sitting next to me watching everything get put together. He passed away about 5 years ago, and I owe him a debt of gratitude for his support of my research. This is my medical director, Dr. John Feller. That's our office in beautiful Indian Wells. If you ever want to come visit, I'll give you a tour. This guy is our technologist, Wes Jones. This guy is Axel Winkel. He was in Schwerin, Germany, now in Gainesville, Florida. He holds the patent with Philips Healthcare to the hardware that we use to do the biopsy and the laser. And this is the late, great Dr. Stuart May, my mentor friend and interventional radiologist. And my professor is Professor Andrew Farrell from University of Edinburgh. And I was the recipient of the 2015 Focus on Research Scholarship from the Research Advocacy Network, and just was awarded the Army Women's Foundation Graduate program legacy scholarship, and I got a $250,000 endowment from Vinnie Smith to form the Focal Therapy Foundation for men who can't afford treatment to be able to fund their treatment. And I think that's the end. I was quick this time. I didn't take your whole night. Does anybody have any questions? Yes, sir. What percent of men do not respond to focal therapy? That's an excellent question, and I'm going to go back to the slide that showed the 22% recurrence rate. So there's a couple things that can happen. When we bring these guys back in for biopsy after they've had their treatment at 6 months, we image and we biopsy the treatment area. Even if we don't see anything that looks funny, we're going to stick a needle in it. And again, this is to make sure there's nothing microscopic there that's going to declare itself later. So in the whole group, we have about a 22% marginal recurrence rate. What that means is that we failed to get the tumor 22% of the time. Is it that we failed and it hung around, or is it that it grew back? That's a question that can't really be answered just yet, but I think the genomic profile of the man is going to give me insight as to whether or not he's going to be one of these guys with a positive biopsy.
How many of the men have multifocal, cancers?
That's a great question. 80% of the time, prostate cancer is multifocal. When you look at the literature in the journal Nature, there was a really great paper published by Ahmed et al. Talking about the monoclonal nature of lethal metastatic disease. While prostate cancer may be multifocal in most cases, there's a dominant index lesion that drives the behavior of the little minions. So if you can get rid of that thing, the theory is that you could quiet the minions. So I describe it sometimes like a pepper shaker. If you have a clear acrylic pepper shaker, and you grind it, you get little bits of pepper on a plate. But if you look up in the chamber, you've got great big peppercorns. Those little flakes you'll never see on MRI, and we don't want to see them because pathologists are actually considering calling it not cancer because nobody does anything with it anyway, right? It's low grade, low volume, low risk. Don't want to see it, don't want to touch it. Don't want to hurt you treating something that shouldn't be treated. But if it's big enough to be seen on MRI, and if we could confirm it's 3+3 and it's large volume, there may still be stuff peppered through there, but you're not going to do anything with it anyway, usually. There's a proportion of maybe 3 to 5% of very aggressive cancers that cannot be seen on MRI because they're so aggressive that the vascularities go on, they are necrotized, you can't see them. So missing 3 to 5% of them versus missing 53% of them, I think the MRI route's a good way to go.
What are the side effects of focal therapy?
So there's a long list of side effects from any kind of focal therapy, whether it's HIFU, cryo, laser, etc. When we make a matrix or a chart comparing focal laser to HIFU or cryo, laser is precise and it's controllable, because we're able to emit the energy over time and deposit it away from structures that are important, and we could turn it off before we damage things. You can't really do that with cryo, and you can't really do that with HIFU. Now, pain, bleeding, infection are the top three. With any kind of thing where you're putting something in the body, pain, bleeding, infection are up there. We manage pain with drugs, Versed and fentanyl. Bleeding has never really been a problem. I had one patient kind of fibbed to me and said he wasn't a smoker, but he was. People that smoke have fibrinogen that doesn't behave properly, so they don't coagulate and clot normally, so they tend to bleed. So we've only really had one guy bleed. Infection, we have a less than 1% infection rate. We give IV Rocephin during the procedure. There are other things that can happen that are kind of on the far end of the spectrum. When you deliver energy with a plastic device, you run the risk that the tip of the device will warm and either carbonize or break off. If it happens in the brain will scar over it and it gets retained. If it happens in the kidney will scar over it and it gets retained. If it happens in a cavity in the prostate near the urethra, it could be passed out like a kidney stone. That's happened once and only once among 151 treatments. Other things that people talk about are erectile dysfunction, urinary incontinence. Those things are associated with any treatment. And in our cohort, we quoted the literature for HIFU and cryo for both of those things, which are around 10% for ED and 5% for urinary incontinence. But no man in the study has suffered permanent urinary incontinence as a result of the treatment, nor is any man suffering ED long-term as a result of the treatment. So if we go back to the slides where I show the IPSS and the SHIM scores, you'll notice there was a little bit of a dip in the IPSS, in the SHIM scores at 3 and 6 months, but then they bounce back at about a year. You can't see it on this one, and you can't see it on that one, and you can't see it on that one. But suffice it to say, they go back to baseline at a year. So the question is, what are the alternatives? So, did that help?
How often are people retreated?
So in our cohort, I'd say there have probably been 8 guys who've been retreated. The first patient that we ever did, he's been treated 4 times. Some of our patients don't have a rectum. Some of our patients are in their 80s. Some of our patients are poor surgical candidates, and we're really the only way to manage their cancer. So they're frequent flyers.
Any other questions?
My question primarily is in the thermogram direction.
Sure.
Infrared.
It's not infrared.
Is any imaging done in this area?
Can you rephrase the question?
Well, okay.
Are you talking about infrared imaging of the tumor tissue or the?
Well, okay. Okay, my infrared experience is all military, okay? So you get to see things that other people don't see.
Yeah. I think you're talking about under the microscope, immunohistochemistry and phosphofluorescence and things of that nature. I'm not an expert in pathology and optical imaging. My expertise is more in diagnostic MRI imaging, so I'm probably not a good person to answer that question.
Okay, because where I'm coming from is, it's a long story. It's over 50 years, but experience with infrared. But anyway, where I'm coming from is the detection early of mammography manifestations of cancers in women's breast tissue. Okay?
Mm-hmm.
There's been a notable degree of hostility in the medical community against using infrared. And I personally asked the question, why? Why?
I wish I knew. I don't know.
Well,
It's not my area of expertise. I'm sorry.
It really, I realize you don't know my background, but some of it's medical as well. And I'm experienced in a lot of different things. Anyway, I just ask it as an open question tonight.
Yeah, and I apologize that I can't give you a good answer, but that's not my focus of study or my area of expertise. Sorry. Yep.
Let me ask you a couple questions. Thank you for an excellent presentation here tonight. The question is that you focused on the prostate gland and the rectal area. What are the other applications of this technology in the body? For instance, is there an application in the kidneys? Is there an application?
Yes, so
Can you explain that?
yeah, when you visited the booth at PCRI, I had 4 textbooks lined up in chronological order that showed a publication in a textbook on focal therapy dating back to the early 90s, where interstitial laser thermal therapy was being used in glioblastomas in the head, in the thyroid, in the head and neck, in the liver, in the kidneys, in the uterus, all over the place. And then in around 2005-ish, the folks in Toronto, Chicago, and Colorado started using it in the prostate. But rather than going with a transrectal route, they went through the perineum, which is the skin surface between where you poop and where you pee. So they had to penetrate the skin, the fat, the muscle, the fascia, the penile bulb to get up into the prostate at a distance kind of like this. And my proposal, after going to Toronto and watching one of these cases being done, which I was fascinated because I thought the laser energy was the right way to go, and the MR guidance was the right way to go, I said, well, why don't you go transrectally? And they said, our protocol says transperineal, so we're going to go transperineal. And I understand that as a researcher, when you write a research protocol, you're saying what you're going to do, and you do what you said you were going to do, and you study it for the length of time you said you were going to do it. You can't change horses midstream, right? Even if something bigger and better comes along, you still got to see it through to the end. So I propose that we do the transrectal route, and again, that's how it started with the whole, hey, you got a gadget and I got a gadget. But it dates way back to the 1990s. All over the body it was used. And it's FDA cleared for soft tissue necrotization in a broad spectrum of medical applications.
So more specifically, can this be applied in the pelvic lymph nodes as an example?
I have not had any experience using it in lymph nodes. Lymph nodes are typically dissected and radiated, so I don't think that that would be a indication.
Yeah. What about the kidney?
Kidneys all the time,
Okay.
all day.
What about the lung?
I have not read of any lungs. I think because the lung is a very mobile organ, and obviously we want to keep it full of air, it's tricky to puncture it with things. So bones, for sure, brains.
Okay. So let's say a person has been irradiated with radiation
External
in a
beam?
particular area. Okay.
Mhm.
So this is a way of targeting that same area.
The thing about external beam radiation or IMRT or even proton, if we see that the rectal wall is thin, and if the tumor is right up on the rectal wall, we won't do it, because that's how you get a fistula. You don't want to burn a hole in the rectal wall. So if the tumor is far anterior, it's okay. We could go ahead and pop that device through the rectal wall and advance it far away and do the ablation and then get out.
So a person that has had radiation, okay, in theory you could come back and
Correct.
and do laser therapy.
Yeah, so when you look at the salvage population, these men, all of them, there were 22 treatments among 16 men. And the one that I like to use as an example, we treated 3 tumors in him. He had brachy, proton, and external beam, 81 years old, poor surgical candidate, tumors in his seminal vesicle, his bladder wall, and his prostate. And they were Gleason 7, 8, and 9, respectively. And we debulked those tumors, and he's still alive. So, and he has no evidence of metastasis yet. So the goal in these guys is palliative and life extending. So anytime a guy comes to us and he has no evidence of distant metastasis and he's got local recurrence, we can go in and zap it. And in fact, we had one patient post-prostatectomy who we went in and lasered him.
So how many people have you treated, okay, with this technology at this point?
We've done 151 treatments, and I don't know the last man count, but it has to be something around 110, something like that. Because remember, some of them get multiple treatments either on the same day of 2 or 3 lesions, or of the same lesion multiple times.
So how long have you been studying? What is the medium statistic in terms of the amount of time you've studied these people?
7 years. So remember, we did the first treatment in 2010,
Okay.
and we're watching them all for 20 years. So the age range in the population is 48 to, I think, 88. And so some of the guys are so young that we can watch them for 20 years. But if we can't watch them for 20 years, we watch them as long as we can. And we're measuring time to biochemical recurrence and rate of biochemical recurrence time to metastasis and rate of metastasis, and all causes of death.
So in terms of how you evaluate success,
It's negative biopsy status and negative MR findings.
okay, and what is that statistic?
And
Success.
the thing that would trigger any further imaging or biopsy is PSA. So when we look at the cases, let's go back to this case study. I'm not sure if I have his PSA on here. I don't see it on the screen. But what I would expect is at the time of his treatment, for grins, let's just say his PSA was 8. In the whole cohort that's been treated, the PSA goes down on the order of 41%. So I would expect his PSA to go down to something like maybe 6 or maybe 5. So whatever is his nadir, whatever is the lowest level that his PSA goes to post-treatment, we want him to hold that. He can bounce around it a little bit, but if he ever goes 2 full points above his nadir, which is referred to as the Phoenix criteria, that's when we would reinsert MR imaging and biopsy if we saw something.
So what's the percentage of people that have been successfully treated?
78%.
That particular, what is it?
78%.
78% over 7 years?
Correct.
Thank you.
You're welcome.
Questions?
How long does it take to achieve native?
By 6 months, sometimes a year, it depends on the guy.
Is there about radiation? Oh, it's not radiation, I guess.
No.
Oh, so it's just 6 or 7. What is the learning curve? Is there any kind of learning curve in doing these procedures?
Of course, like anything, there's a learning
How
curve.
many would you say?
If I've been playing guitar for 2 weeks versus if I've been playing guitar for 20 years, I'm not Eric Clapton,
Well,
and I never will be. So the good,
In Dr. Feller's case, he did
yeah, so the
150.
good news about Dr. Feller is he co-developed the technique. So I conceptualized it and I wrote the application requirement specification for the hardware and the software. So I was intimately familiar with how it worked. And his team gave me feedback for requests for enhancement. My design history file had many surveys from all over the world, but many of them from Wes Jones, the tech, Dr. Feller, and Dr. May. So they helped build the system, essentially. So they know it as good as or better than me. So the learning curve, I guess there kind of wasn't one because we developed it.
Okay. There's some doctors that are doing this as well.
There's a handful of doctors that are doing it.
Texas and New York and places. How are things working out for them?
You'd have to give them a call and ask them. I can only speak to what we do because, yeah, when I teach people and when people come to workshops, I warn them, you don't have any real business putting a laser in somebody until you've done at least 100 in-bore MR-guided biopsies. You're not going to kill a man doing a biopsy, but you could really hurt somebody doing a laser if you don't know what you're doing.
My question is, I remember you from
8 years ago? Just kidding. A while ago. A while ago.
yeah, it was 2016, yeah. So it was just about a year ago, and I was really impressed with your treatment here. And I want to know now, is your biomarker part of your treatment? Is that standard now?
No, so remember what I said before, when you write a protocol, you say what you're going to do, how you're going to do it, and then you do it, and you keep documents to prove that you did what you said you were going to do? That's what a clinical trial protocol looks like. Our inclusion criteria only is Gleason score, not genomics, because when I wrote the protocol in 2014, this test didn't exist. But now that it does exist, even though it's not inclusion criteria or exclusion criteria, I will sit with the man and myself or Dr. Feller will talk to him about what his genomic profile reveals to us in our experience. And it'll give us a better handle on, should this even happen in this case. Does that make sense?
Okay, so you still do it, but it's not
Right, and often what'll happen is the man will come in for biopsy, he'll come back Gleason 6, we'll do his treatment. Because the genomic test can take 4 to 6 weeks, we'll get his genomics down the road, and then we'll sit him down and say, this is your genomic profile, this is what we think, this is what you can expect, and everyone's got the right grasp on reality, if you know what I mean. Yes, sir.
How much does the cytogenomic add to the Gleason and the clinical observation?
You know, in my opinion as a researcher, I think it's very, very valuable. In a small cohort of 20 men, I had 16 guys with low-risk genomics. All 16 had negative 6-month biopsy. It's a small cohort, but it bodes real well for the test.
One more question, then we're going to let our speaker.
I could bring the kids with me this time so I could stay as late as you want. Last time I had my children with me.
How are they doing?
They're doing great. Thank you for asking. I'll tell them the gang says hi.
I had a question about when you showed the temperature, you said you started out with 99 degrees.
Yeah, so we do a non-therapeutic dose first. And the reason why we do that is we want to make sure that we see the thermal energy being deposited in the geography that we want in multiple planes.
And then you said you raised the temperature
Right.
to a point where
So-
there was damage. What is the difference in that temperature range?
So do the math in your head. It's a 15-watt laser, and we'll apply 30% energy-ish for the test dose. And then we'll go up to like 90%. 90% is somewhere around 13, 14 watts, and that's around 60, 70 degrees Celsius. And that's enough to induce cell death.
Okay, let's give Bernadette a great hand for her.
Thank you.
All the way from Desert Springs, and we really appreciate her presence and what she had to say. And show our appreciation. It's not a great deal, but here's a
Thank you.
cup for your
My mug.
bar when
Thank
you're
you.
traveling.
And those of you who may have questions down the road, Larry knows where to find me. Give him a jingle and he can set you up with a phone consult or a call. Thank you for
Thank you.
making
We'll see
time.
you here next month, hopefully. You have any cards? Did a great job.
Thank you, sir.
Yeah, they did.
Thank you.
What's this about you transferring to Germany?
So on March 29th, I did a lecture for Professor Alvar Zalai at University of Würzburg.
Okay.
And he told me to look into the camera and look at the team in Würzburg. There is a chair empty at the table. I want to be in that seat. So, okay.
Okay, can I pull the plug?
All
Yeah, be
seriousness, he
careful
invited
with
me
this
to
or
exit out of the program at Edinburgh and finish my
Okay.
PhD under him. And
Oh, that's wonderful.
yeah, so rather than a PhD in imaging science,
It's
it's
been a long
in
day.
tumor immunology
Good,
imaging.
good.
Yeah.
So we're
Means
using
you're living.
new techniques to do imaging and
How about
treatment
you?
response to immunotherapy
Haven't been
or
feeling
laser
good.
or both.
Really?
So
I know you
how
said
long
you're
is it?
coughing there, and I heard you a couple
I'm
times.
going to be
hell of a
inducted this
cough.
year, but my lab is in Indianapolis, and Dr. Zalai goes back and forth between San Diego and Würzburg. So he's at my disposal no matter where he is or where I
So
am.
where will you be positioned?
In New Orleans.
Give me
My lab will be there.
You know,
Okay.
So I'm
it's
gonna
pretty well
check
gone.
my
It only lasts,
We're getting
I was
the
amazed how
old
quick.
one. I've already got
a
access.
spider.
I'm not gonna get
And I mean, I
gallium
had a great
68,
big,
it's just
almost
enough
looked like
to
a
have
blood
some.
blister, and
We
there,
have a
but
negative
then right
pressure,
beside it was another one. I think I must have got.
ventilated
I was out working in the yard.
You know, reaching under that.
laboratory.
No,
So,
By the time I
did a great job.
figured out what it was,
Really
you know,
impressed
it
with your, did it swell up? Your study.
Huh?
Did it swell up? I see
yeah.
results.
Yes.
And I see
Well,
your
look, and
efforts
actually,
in many,
I
many
had-
different ways.
I finally poked the needle and I thought,
You're a very honest person, okay? And besides being very
No other way to
capable.
be, right?
Yeah, yeah.
I want to talk to this dude. He sounds like you got some good ideas too.
Yeah. Dr. Fuller,
Feather.
excuse me.
Like
A
Bob
Fuller,
Feller.
there's a Fuller and there's a Feller. Is he lined up to be with us?
For June of next year.